Hello, and welcome to today's webcast about Medicare Part D reform. My name is Hannah Lynch, and I'm the Associate Director of Federal Government Relations and Health Policy here at NPF. During today's webinar, we will discuss policies that Congress should adopt to help reduce out-of-pocket costs for members of the psoriatic disease community who receive prescription drug coverage through Medicare Part D. People with psoriatic disease rely on specialty tier medications to control their condition and associated comorbidities, but high out-of-pocket costs often prevent them from filling their prescription. A 2019 National Psoriasis Foundation survey of people with psoriatic disease found that over 4 in 10 Medicare beneficiaries experience strain due to the cost of their biologic treatment. NPF's advocacy team and its volunteer advocates continue to engage lawmakers on reform options that would lower a patient's out-of-pocket costs. This webinar will provide an overview of the Medicare program with a focus on the prescription drug benefit Part D. Once we have a baseline understanding of the Medicare Part D benefit structure, we will discuss how Congress can address high out-of-pocket costs in Part D. We'll conclude the webinar by sharing ways that you can get involved with our advocacy efforts on this issue. Let's start off with an overview of the Medicare program. Medicare is the federal insurance company for people who are 65 and older, certain people with disabilities, and people with end-stage renal disease, sometimes called ESRD. A person who obtains insurance coverage through Medicare is often referred to as a beneficiary. As of 2020, about 60 million Americans are covered by Medicare. Within the Medicare program, there are 4 parts. Part A is essentially hospital insurance, covering things such as inpatient hospital stays, care in a skilled nursing home facility, and hospice care. Part B is medical insurance, covering certain doctor's visits, outpatient care, and preventative services. Part C is for beneficiaries who choose to use a Medicare Advantage plan, also known as Medicare Private Health Plan. These plans still provide all Part A and B services, but they do so with different rules and costs. Medicare Advantage plans can also cover additional services not traditionally covered by Parts A and B, such as vision and dental care. And finally, Part D is the prescription drug coverage in Medicare. This helps cover the cost of prescription medications, including shots and vaccines. In 2019, 45 million Americans were enrolled in Medicare Part D. Medicare beneficiaries can use what is known as Original Medicare, or the standard federal health plan offered. Some also enroll in supplemental insurance called Medigap, which helps to fill the cost-sharing gaps in Original Medicare by helping beneficiaries pay for their deductibles and copays. Medigap only helps lower cost sharing in Part A and B, not Part D. To have your prescription drug costs covered by Medicare, a patient must sign up for a private drug plan or use a Medicare Advantage plan that includes prescription drug coverage. Part D is provided through private insurance companies that have contracts with the federal government and not provided directly by the government. There are 4 phases or periods of Part D coverage. First, you have a deductible. Medicare sets the maximum deductible, but it can vary by plan. And in 2021, the maximum deductible is set at $445. After you meet your deductible, your plan will help pay some of the costs for your covered prescription drugs, and you will pay a copayment or coinsurance, a % of your prescription's cost. During the next phase, called the initial coverage period, your plan will pay 75% of the drug's cost, and you're responsible for 25%, or a copay depending on your plan. How long you stay in the initial coverage period depends on your drug's cost and your plan's benefit structure. For most plans in 2021, the initial coverage period ends after you have accumulated $4,130 in total drug spending. This includes the amount you and your plan have paid for your covered drugs. Once you've hit that amount, you move into the coverage gap, or what is commonly known as the donut hole phase. Calling this phase the donut hole is kind of misleading because the donut hole was technically closed for all drugs in 2020, meaning that when you enter the coverage gap, you will continue to be responsible for 25% of the cost of your drugs. Although the donut hole has closed, you may still see a difference in cost between the initial coverage period and the donut hole because there is no longer a standard copay. In all Part D plans, after you have paid $6,550 in out-of-pocket costs in 2021, you will reach catastrophic coverage. During this period, you pay significantly lower copays or coinsurance for your covered drugs for the remainder of the benefit year. During catastrophic coverage, you will pay 5% of the cost for each of your drugs, or $3.60 for generics and $8.95 for brand name drugs, whichever is greater. Using that information, let's do an example scenario of someone taking a prescription drug that costs $5,000 per month. In January, they meet their deductible amount and owe 25% of their remaining cost, which would equal about $1,584, putting them through the initial coverage phase at the beginning of the year. In February through April, they are in the coverage gap phase and still pay 25% of their drug costs, a total of $1,250 each month. Then in May, they pay almost the full 25%, but because their total out-of-pocket spending hits $6,550 for the year, catastrophic coverage kicks in. For the rest of the year, they only owe 5% or $250 per month. While this is a fictional example, it is the reality for many people with psoriasis and psoriatic arthritis who have Medicare Part D. With this example in mind, let's explore why people see increased costs when they switch to the Part D program from commercial insurance. There are two main factors that may cause patients to see an increased cost in their prescription drug spending. The first is that unlike most commercial insurance plans, Medicare does not have an out-of-pocket maximum. As more specialty drugs come to the market, a 25% coinsurance becomes increasingly unaffordable for most. In 2017, the number of people reaching the catastrophic phase was 1 million, more than double that number in 2007. Even in the catastrophic phase, beneficiaries still owe 5% of their prescription drug costs, which can still be a lot of money for drugs with high list prices. The second is that due to the federal anti-kickback statute, drug manufacturers are not allowed to offer copay cards to people with federally funded health insurance. That means anyone with Medicare, Medicaid, TRICARE, or Indian Health Services can't use copay cards. A 2019 NPF survey of individuals with psoriasis and psoriatic arthritis found that 54% of individuals with commercial insurance used manufacturer copay cards. When they switch to Medicare, their costs may increase because they can no longer use that form of patient assistance. The anti-kickback statute was created so that copay assistance programs would not persuade a patient to use one treatment over another when a federal health program is paying the bill. However, for most psoriasis treatments, there are no generic alternatives, and even the lower-cost specialty treatments are still expensive for patients. Now that we understand the mechanics of the Part D program, let's talk about what Congress can do to reduce costs for seniors. First, Congress should create an annual out-of-pocket cap for Part D. This concept is not new. In fact, Part D is one of the only programs that does not have an out-of-pocket maximum. The Affordable Care Act actually created out-of-pocket maximums for marketplace and employer health plans, but this did not apply to Medicare. A cap in Part D would help Medicare beneficiaries, many of whom live on fixed incomes, budget for the year. Second, Congress should pair a cap with what is called a smoothing mechanism to help beneficiaries reduce high upfront costs by paying their out-of-pocket costs throughout the year in monthly installments. There is research to show the value of this approach. For example, research from the IQVIA Institute for Human Data Science shows that in 2017, 69% of commercially insured patients did not fill their new prescriptions when they had to pay more than $250 out of pocket, That's more than 2/3 of prescriptions. Pairing an out-of-pocket cap with a smoothing mechanism could help bring monthly costs near or below $250 per month, depending on the amount of the cap, which would help improve treatment adherence and, as a result, improve overall health outcomes. There's been bipartisan support in both chambers of Congress for an out-of-pocket cap with a smoothing mechanism, and all of the recently proposed drug pricing packages include a provision on both policies. Recent policy proposals outlined in the chart show that most established an out-of-pocket cap at $3,100, with H.R. 3 setting the limit at $2,000. All proposals included language regarding a smoothing mechanism as well. Even the highest amount of these proposals would cap monthly out-of-pocket spending at around $258. NPF is not advocating for the cap to be a specific number, but rather that Congress should hurry to enact such an important policy. Now more than ever, given the financial implications of the COVID-19 pandemic, seniors cannot afford to wait another year for an out-of-pocket cap on Medicare Part D. NPF continues to advocate on this issue with members of Congress, asking them to support capping annual out-of-pocket costs while also addressing the extraordinary upfront costs in Medicare Part D by spreading the costs across the benefit year. Now that you know more about Medicare Part D and how Congress could help improve the program, what can you do to help these policy ideas turn into law? There are many ways NPF's patient advocates can get involved on this issue, and you don't have to be a Medicare beneficiary to help. You can send an action alert email to your member of Congress asking them to support these reforms. If you have a story about out-of-pocket costs in Medicare, we hope you will share it with us. It is important that members of Congress hear from you, their constituents, to know that this is an issue you care about and want them to address. If you are currently experiencing issues with your out-of-pocket costs in Medicare or want more information about the program, please contact our Patient Navigation Center, who can share resources about the options that may be available for you. Please see the webinar notes for the links to these items. Thank you for taking time to learn more about the Medicare Part D program and how you can help NPF advocate for an out-of-pocket cap.